Moving along, this lecture will discuss uterine cancer. 60,000 women are diagnosed with uterine cancer annually, and 10,000 of them will die from it. Unfortunately, even though this form of cancer affects Caucasian women more frequently, they die less often than Black women. There are several types of uterine cancer, but the most common is endometrial, followed by uterine sarcoma. There are risk factors associated with this type of cancer. All have continuous or excessive exposure to unopposed estrogen as the common etiology. Estrogen replacement therapy without the use of a progestin to treat menopausal symptoms was, and in some cases, continues to be a common practice. This increases the risk of developing endometrial hyperplasia and eventually a cancer. Infrequent periods and never being pregnant are risk factors due to the month-after-month stimulation of the endometrium with no break. Obese women, especially those with polycystic ovarian syndrome, abbreviated PCOS, have a high incidence of endometrial cancer due to the high levels of estrogen that is unopposed. These women do not ovulate, therefore the endometrium is not matured by the progesterone. Another risk factor is the length of time a woman has menstrual cycles. This means from menarche to menopause, not how long any given menses lasts. And then finally, women who are taking tamoxifen for breast cancer have an increased risk of developing uterine cancer. The beauty of the uterus is it tells us when something is wrong by bleeding. The cardinal symptom of a potential uterine cancer is unexplained bleeding once pregnancy is ruled out. This is especially true if it occurs after menopause. Other less common signs and symptoms include an unusual vaginal discharge or complaints of pelvic pain, pressure, or the presence of a mass. If a patient feels pelvic pain, pressure, or a mass, this usually means there is advanced disease. Uterine cancer is diagnosed through the use of a transvaginal ultrasound that visualizes the thickness of the endometrium. A normal endometrial stripe is less than 11 millimeters. If it is abnormal, the MD or NP can perform an endometrial biopsy right then and there in the office. If the patient cannot tolerate the EMB, a DNC can be performed in the OR. Look at the ultrasound on the left. The area that is darker black-gray is the uterine muscle itself. Between the two star markers is the thickness of the endometrium. This one is normal at 1.8 millimeters. Now look at the ultrasound on the right. This is a very thick endometrium and is suspicious for endometrial cancer. In this case, the nurse will set up for an EMB and assist the provider with the procedure, which is done under local anesthesia. The MD or NP anesthetizes the cervix only, not the uterus, so this procedure is quite uncomfortable due to the uterine cramping that occurs as the instruments are inserted through the cervix. These pictures give you a visual of the procedures. The two on the left are the EMB done in the office using a flexible plastic curette. The picture on the right is a DNC, and hopefully this is done in the OR. The provider inserts the curette into the uterus and scrapes tissue 360 degrees around from the uterine cavity. The sample is sent to pathology for evaluation and diagnosis, and this is your job. If the patient didn't take an NSAID before or during the procedure, she should be instructed to take 2 ibuprofen with food as soon as she can to minimize the cramps. The patient may need an outpatient DNC if the os is stenotic or if she is intolerant of the offer's procedure. In this case, the nurse needs to explain the need for being NPO, sends off a CBC and a Chem 7, and may need to send the patient for an EKG if she is over 50 years of age due to general anesthesia risks. The biopsy will tell us if the tissue is normal, hyperplastic, or malignant. If endometrial hyperplasia is present, the patient is prescribed medroxyprogesterone, also known as Provera, 10 milligrams to take orally once daily for 14 days. You need to instruct the patient she should expect a withdrawal menses upon finishing the prescription. Like most cancers, management of uterine cancer includes a multidisciplinary approach beginning with surgery. The surgical treatment for uterine cancer is a total abdominal hysterectomy with bilateral salpingo-oophorectomy, also known as a TAH with BSO. In the postmenopausal woman, a TAH with BSO will be performed because she no longer needs those ovaries. The picture on the right shows the various types of hysterectomies. For cancer, the approach is the most aggressive, including lymph node dissection. After surgery, based on the pathology, further treatment may include chemotherapy and radiation. At this point, the patient is referred to a GYN oncologist and radiation oncologist. Your nursing interventions include being great at triaging phone calls. When a patient calls to complain of abnormal vaginal bleeding, you need to ask the patient how old she is. How is the bleeding abnormal? Is there any chance of pregnancy? And when was the last normal menstrual period? If she tells you it's been 10 years since she had a period, that is an immediate red flag. The bottom line is this patient needs to come in and be seen. You need to educate your patient about the medical management. Once the physician has decided what is going to occur, help the patient to navigate through appointments, surgery, obtain lab work, and sign consents. The nurse needs to obtain pathology reports and give it to the provider. Some of these results need to be sent to the specialists also. Post-op care of the post-hysterectomy patient should follow the standard guidelines presented in the GYN malignancy overview lecture. Provide this patient with psychological support, as this woman is informed of the diagnosis and management of the cancer. This ends the lecture about uterine cancer.